Welcome to the deep dive. Today, we're diving deep into what I think is an absolutely essential and frankly high-stakes area of pediatric practice. We're talking about the care of children who are experiencing alterations in behavior, cognition, or maybe development. And this isn't just theoretical stuff, right? It's really about providing immediate, effective support when kids are potentially at their most vulnerable.
Exactly. And, our source material really points to a difficult reality here. Mental health issues, they're often called the new morbidity in pediatrics. They affect somewhere between, say, 14% and 20% of all children.
Wow, that's a significant number.
It is. But here's the real crisis point, I think. Only about 1 in 5 of those children, so 20%, are actually identified and getting any help from their primary care providers.
1 in 5.
Yeah.
That's an 80% gap. That's staggering.
It really is. So our mission today is pretty laser focused. We want to give you the clinical leverage points, the tools, the assessment tips, the nursing interventions that can help you participate in that early identification, help close that gap.
Okay, so we'll cover the foundation of behavioral management, some critical assessment cues, and then really zero in on high-impact nursing care for specific disorders, stuff like ASD, ADHD.
Yeah, and right through to really life-threatening issues like eating disorders and, unfortunately, violence and abuse as well.
All right, let's start at the beginning then. Let's unpack that foundational question. What actually shapes a child's behavior? We know it's complex, never just one thing.
That's right. The sources highlight this really complex mix. You've got biological and genetic factors, of course. Then there's their physical health, their nutrition, their environment, their unique temperament.
And those family interactions, caregiver responses, those are huge too, right?
Absolutely critical.
Yeah.
And all that complexity, it makes identification tricky because, well, what looks normal varies so much depending on the child's age and development. What's really crucial to understand, though, is how kids often respond to stress. It's often through rapid behavioral regression.
Regression, meaning they fall back to earlier behaviors.
Exactly. When they face stress or fatigue or pain, they instinctively fall back to earlier, maybe less mature patterns of behavior. So if you see that happening persistently, you really have to investigate. Could there be an underlying mental health concern?
Okay, so that's a key flag. Now, thinking practically, on a busy shift, specialized therapists might not always be right there. What specific immediate behavior management techniques can a pediatric nurse actually use day to day?
Right. This is key for bedside nurses. Consistency is absolutely non-negotiable. That means setting clear limits and then holding those limits.
So no arguing or bargaining?
No, none of that. The child needs to feel the security that comes from predictability. We also rely heavily on some pretty simple principles, like operant conditioning. So actively use a low-pitched, calm voice. Try to ignore the inappropriate behaviors. That's a technique called extinction. And this is important. You have to simultaneously use positive reinforcement. Give immediate, sincere praise for every little effort, every accomplishment.
That distinction feels really key. It's not just ignoring the negative. Right.
You have to immediately pivot and reinforce the positive action they did take.
Precisely. You have to actively shape the behavior you want to see. Now, when we talk about more formal treatments, the types of therapy target different needs. So behavioral therapy is that basic stimulus response foundation, reinforcing the desired action.
Makes sense.
Play therapy is great for younger kids. It encourages them to act out feelings they maybe can't put into words yet.
Okay. And then when we get into maybe the heavier psychological lifting, we often hear about CBT and DBT. Can you give us a quick distinction between those two? They're kind of the gold standards, aren't they?
They really are. So cognitive behavioral therapy, CBT, is all about identifying and changing those faulty or negative thought patterns that lead to unhealthy reactions or feelings.
Right. Changing the thoughts to change the behavior.
Exactly. Then dialectical behavioral therapy, DBT, well, that's highly specialized. It focuses on teaching skills to manage really intense negative emotions. You see it used a lot in high-risk situations, like for individuals with chronic suicidal ideation. Okay, so DBT is more for intense emotional dysregulation.
That's a good way to put it. And finally, for kids who are maybe high acuity, pose a safety risk to themselves or others, there's milieu therapy. This provides a highly structured, safe environment, like in an inpatient unit, designed to promote social and adaptive skills 24/7.
Got it. Okay, let's shift gears into the nursing process itself. We always start with assessment, and the book emphasizes it must be individualized. Beyond the general health history, what specifics should really make our ears perk up regarding behavioral trouble?
Yeah, good question. We need to kind of look backward and forward. So, backward. Get a comprehensive prenatal and birth history, any past medical issues, especially neurological events, and critically, a family history of mental health disorders. That's often a big piece.
Okay, that's looking back. What about currently?
Forward or currently, you're looking for changes in patterns. Things like altered sleep or eating habits, new problems popping up at school, maybe increased risk-taking behaviors, or even a sudden change in friendships, like withdrawing or losing friends. These are all potential flags.
And when we're actually observing the child physically, we're looking beyond just the obvious, right? Looking for subtle cues.
Definitely. You need to observe their clothing. Is it appropriate for the weather? Clean? Their eye contact, their posture, and importantly, their affect.
Affect. Let's clarify that. It's different from mood, isn't it?
Yes, and we need to be precise here. Affect is the external visible facial display of emotion. Is it flat? Is it exaggerated? Is it appropriate to the situation? We're checking if that outward display matches their internal mood or what's going on around them.
Okay, that makes sense.
Physically, don't forget the basics growth checks. Weight, height, and head circumference for kids under 3. Growth often tracks with developmental health. And always, always be looking for physical clues that might suggest harm. Bruising patterns that don't match the story, for example. Or maybe thinking about eating disorders. Things like eroded tooth enamel from vomiting, or that soft, sparse body hair called lanugo.
Okay, lots of clues there. Let's transition those findings into some high-impact nursing interventions. Say a nurse identifies imbalanced nutrition, less than body requirements, maybe linked to an eating disorder. What's the action plan?
Right, so the first most vital goal is obviously to get their weight and nutrition safely back on track. This involves some really specific, often non-negotiable interventions. Things like structured meal times, maybe using mutual contracts if appropriate for their age, and minimizing attention if they try to refuse food. Don't make it a power struggle.
Okay.
But the intervention that is absolutely critical for patient safety is continuous supervision during the meal and for 30 minutes following.
Continuous supervision for a full 30 minutes after eating. Why is that so crucial? What's the life-saving rationale there?
It ensures they cannot conceal food or throw it away, or, most urgently, induce vomiting right after eating. It basically prevents those destructive behaviors exactly when they're most likely to happen. It's a safety measure, pure and simple.
Got it. Okay, let's take another example. What if a child has a diagnosis like ineffective impulse control? This could cover anything from temper outbursts to maybe even violence. The interventions would shift then, wouldn't they? More towards building security and trust?
That's right. The focus changes. Interventions here might include performing an age-appropriate mental status exam, establishing a strict, consistent daily routine, because routine equals security for many kids.
Right, that predictability again.
Exactly. And crucially, providing validation of the child's thoughts and feelings. This helps build trust. You're validating the feeling even if you can't validate the action itself, like, I see you're really angry right now, even if hitting wasn't okay.
That's a powerful distinction. Validate the emotion, not necessarily the behavior. Okay, moving now into some specific developmental disorders. Let's start with learning disabilities, or LDs. The text says they affect about 10% of children. How is it defined?
So our source defines it as an innate cognitive difficulty. Basically, it means the child achieves less academically than you'd expect based on their overall intellectual potential. It's not about effort. It's about how their brain processes certain information.
And there are different types, right?
Yes, we need to recognize the common ones. There's dyslexia, which impacts reading, writing, spelling. Dyscalculia involves difficulties with math concepts and calculations. Then dyspraxia, which affects motor coordination and dexterity, and dysgraphia, difficulties with the physical act of writing or written expression.
Okay. And as nurses, what's our immediate priority here? It's not diagnosing, is it?
No, definitely not. Our priority is advocacy. The Individuals with Disabilities Education Act, IDA, mandates that these children receive appropriate support in school. It usually means pushing for an Individualized Education Plan, or IEP. Getting that IEP in place is a nursing non-negotiable, really. We need to support families in advocating for that.
Good point. Okay, next up, intellectual disability, or IB. The definition involves significant limitations in both intellectual functioning and adaptive behavior, starting before age 18.
Right, and ID isn't just one thing, it exists on a spectrum. The book describes severity categories, sort of like levels. Mild ID is the most common, about 85% of cases. These individuals can usually manage independent activities of daily living, ADLs. Then you have moderate, severe, and profound ID, each requiring increasing levels of support, especially for complex tasks. Moderate might need substantial support, while severe and profound often depend on support for most aspects of daily life.
For early identification, though, is there one sign that's particularly sensitive?
Yes, the text highlights delayed language development. Think about it, speech requires incredibly complex cognitive processing. So significant delays here are often the earliest and maybe the most reliable indicator of potential ID.
That's a key takeaway. And if a child with ID is hospitalized, what's the management approach?
The main goal is to minimize stress and disruption. So you want to strictly maintain their usual home routine as much as humanly possible. Follow any feeding protocols or motor supports they already use. And depending on the level of disability, close supervision is often essential for safety.
Makes sense. Keep things predictable. Now let's talk about Autism Spectrum Disorder, ASD. The book mentions onset in infancy or early childhood, affecting about 1 in 68 children.
Yeah, the pathophysiology is complex, but it's mainly thought to be genetic. Clinically, it typically involves impaired social interactions, communication difficulties, both verbal and nonverbal, and often those repetitive or perseverative behaviors or interests.
The early warning signs seem crucial for pediatric screening here. What should nurses be looking for?
Absolutely critical. The take note box in the chapter highlights these. We need to watch for things like failure to orient to their own name by 12 months, lack of eye contact, not using gestures like pointing or waving. Also, a lack of interest in what we call joint attention, that back and forth sharing of focus with someone else, like looking where you point. And maybe the most concerning sign is any loss of language or social skills they previously had at any age. That's a major red flag.
Okay, regression is always a concern. Now, the text mentions there's no cure for ASD, but what about management? There's some strong evidence for certain interventions, right?
Yes, the focus is on optimizing functioning. And the evidence-based practice finding highlighted is really significant. Early intensive behavioral intervention, EIB, we're talking 20 to 40 hours per week.
Ugh.
It's a major commitment, but it's been proven to significantly improve adaptive behavior, communication, and overall function for many children with ASD.
That's intensive. And what about when a child with ASD is hospitalized? What's the key nursing management strategy?
Routine, routine, routine. The absolute top priority is maintaining a rigid, unchanging routine. Any deviation from their expected schedule can trigger severe anxiety, agitation, or even aggressive acting out in a child with ASD. So sticking to that schedule is paramount for safety and reducing distress.
Okay, rigidity is key there. Let's move to ADHD, Attention Deficit Hyperactivity Disorder. The text calls it the most common neurodevelopmental disorder, affecting 8% to 11% of school-aged kids.
Right, and it's important to remember the subtypes. There's the predominantly hyperactive impulsive type, the predominantly inattentive type, which used to be called ADD, and the combined type.
And the diagnosis isn't just based on being bouncy, right? There are specific criteria.
Definitely not. The criteria, summarized from the DSM, require having 6 or more symptoms of either inattention or hyperactivity impulsivity. These symptoms have to persist for more than 6 months, show up in 2 or more settings, like home and school, and clearly interfere negatively with their social, academic, or occupational functioning.
Okay, let's talk treatment. Medications, particularly psychostimulants like methylphenidate, are common. How do they work?
So psychostimulants primarily work by increasing levels of certain neurotransmitters, which helps improve focus and attention span. That's the key benefit. But here's an important clinical point the book makes. They usually do not significantly reduce the child's actual physical activity level itself. They help them focus better, even if they're still active.
Interesting distinction. And what about side effects?
The most common adverse effects we monitor for are things like decreased appetite, which can affect growth insomnia or trouble sleeping, and sometimes the development or worsening of tics.
Okay, and this actually leads to a really practical nursing management tip regarding medication compliance, doesn't it?
Yes, exactly. We really need to teach families about and advocate for using the extended release formulations of these medications whenever possible,
Why is that so important?
because it avoids the need for a lunchtime dose at school. Having to go to the school nurse every day for medication can make the child feel singled out, different, stigmatized.
Leading to non-compliance.
Precisely. They might forget or refuse to go. The long-acting forms, taken once in the morning, bypass that whole issue and significantly improve adherence. It's a simple thing that makes a big difference.
Great practical advice. Okay, let's shift now into some of the more clinical mental health disorders, sometimes with higher stakes. What about Tourette syndrome?
Tourette's is characterized by esotics. These are sudden, rapid, recurrent, non-rhythmic, stereotypical movements or sounds. To meet the criteria, the child must have multiple motor tics and at least one vocal tic present for over a year. And it's important to know there's a really high comorbidity rate. Up to 60% of kids with Tourette's also have ADHD or OCD.
Wow, high overlap. How do we manage genetics from a nursing perspective?
Well, it's helpful to know that child is often worsened with stress or fatigue, but they tend to improve when the child is focused on an activity they enjoy, like watching TV or reading or playing a video game. In school, we can advocate for accommodations like allowing take breaks where the child can leave the classroom briefly if needed, and maybe untimed tests to reduce pressure.
Okay, support and accommodation. Now, let's revisit eating disorders, specifically anorexia nervosa and bulimia.
Right, so anorexia nervosa is characterized by that dramatic weight loss, often due to severely restricted intake, maybe excessive exercise, and a distorted body image.
Yeah.
Patients often have a very low BMI. Bulimia nervosa, on the other hand, involves cycles of binge eating, followed by purging behaviors like self-induced vomiting, laxative abuse, or excessive exercise. These individuals are often near normal weight or even slightly overweight, which can make it harder to spot initially.
What are some key physical assessment findings for each?
For anorexia, you might see a cachectic appearance severely underweight, loss of subcutaneous fat. That soft, sparse body hair logo can appear. Vital signs are often affected. Bradycardia, slow heart rate, hypotension, low blood pressure. For bulimia, look for clues related to purging. Calluses or scars on the knuckles Russell's sign from inducing vomiting. Dental erosion, particularly on the back of the teeth, from stomach acid.
Okay. And you mentioned earlier the critical intervention for hospitalized anorexia patients regarding nutrition.
Yes, and it bears repeating because it's so critical. For a severely malnourished patient hospitalized with anorexia, we absolutely must initiate slow refeeding. Starting nutrition too quickly can be incredibly dangerous.
Why? What's the danger? You mentioned refeeding syndrome.
Exactly. Refeeding syndrome is the potentially lethal complication we're trying to avoid.
We hear that term a lot. Can you break down what the core danger is? Why is it so dangerous?
It's essentially a massive, rapid shift in fluids and electrolytes, especially phosphate, potassium, and magnesium, that happens when nutrition is reintroduced too quickly after a period of starvation. The body just can't cope with that sudden metabolic demand. This electrolyte imbalance, particularly the low phosphate hypophosphatemia, can cause severe complications. Cardiovascular collapse, respiratory failure, seizures, coma, basically multi-system organ failure.
So slow and steady is literally life-saving.
Absolutely. It requires incredibly careful monitoring of vital signs, intake and output, and labs, especially electrolytes, during those initial days of refeeding.
Okay, that's crucial. Let's move to mood disorders, depression, and bipolar disorder. The text notes the incidence is concerningly high, especially in adolescents, maybe 8%, with girls affected about twice as often as boys.
It is high, and tied into that is the prevalence of suicidal ideation, which is truly shocking. The CDC data mentioned in the chapter from 2017 found 17.2% of teens had seriously considered suicide, and 7.4% had actually attempted it.
Those numbers are just devastating, and they really underscore a critical nursing role, don't they?
They absolutely do. It translates directly into a non-negotiable nursing priority. Mandatory screening of all children and adolescents for depression. We need to be using standardized tools like the CDR-SR or the CDI mentioned in the text. And if any potential problem is identified, or if a child expresses any suicidal ideation, that requires immediate referral to mental health services and, crucially, close observation and safety precautions while they're in our care. We cannot drop the ball on this.
Absolutely paramount. Okay, what about anxiety disorders? The book calls them the most commonly diagnosed psychiatric condition in childhood.
That's right. And it's important to differentiate normal developmental fears from a disorder. Infants are scared of loud noises and strangers. Toddlers fear the dark or separation. Teens worry about school or social performance. That's normal.
So when does it become a disorder?
It becomes a disorder when the anxiety is excessive, persistent, causes significant distress, and interferes with their daily functioning school, friendships, family life. The types include Generalized Anxiety Disorder, GAD, that sort of unrealistic, excessive worry about lots of things, social phobia or social anxiety, separation anxiety disorder, OCD, obsessive compulsive disorder, where compulsions reduce anxiety about obsessive thoughts, and PTSD, post-traumatic stress disorder.
Since kids rarely walk in and say, I feel anxious, what are the assessment clues we should rely on, especially the physical ones?
That's a great point. Somatic complaints are huge.
Yeah.
Persistent headaches or stomach aches that don't have a clear medical cause are very common ways anxiety manifests physically in children. You also look for those physical signs of chronic tension or nervous habits, maybe hair loss from repetitive twisting or pulling, trichotillomania, or nail biting that's so severe it causes skin breakdown. These can be subtle signs of underlying anxiety.
Good clues to watch for. Finally, we have to cover the critical and often difficult issue of abuse and violence. This is one area where our responsibility as nurses is very clear-cut, legally speaking.
Absolutely. The text stresses this, and it's vital. Healthcare professionals are mandatory reporters in all states. If you suspect child abuse or neglect, you are legally obligated to report it to the appropriate Child Protective Services agency.
No ambiguity there. What are the main types of maltreatment we need to be aware of?
The major categories are physical abuse, sexual abuse, emotional abuse, which can be harder to spot but is just as damaging, and neglect, which is the failure to provide the basic necessities like food, shelter, supervision, medical care, or education. Neglect is actually the most common form.
And what are some key assessment red flags that should make us suspect abuse?
Knowing these is essential for fulfilling that mandatory reporting duty. Look for a history or explanation of the injury that is inconsistent with the actual injury observed. Any significant delay in seeking medical treatment for an injury. Bruising on infants or children who aren't yet mobile, non-ambulatory children shouldn't have bruises usually. Specific suspicious injury patterns like burns that look like they fit a stocking or a glove, suggesting immersion, or injuries to specific areas less likely to be accidental, like the chest, head, neck, or abdomen.
Okay. And there's particularly complex type mention. Medical child abuse, sometimes called Munchausen syndrome by proxy. What should make a nurse suspicious of this?
This is tough because the caregiver, usually the parent, appears so caring and involved. But the warning signs include clinical findings or symptoms that simply do not match the reported history provided by the caregiver, or symptoms that mysteriously improve or disappear when the suspected perpetrator, the caregiver, is removed from the child's bedside or not present. Repeated hospitalizations without a clear medical diagnosis being established should also raise a flag.
Tricky situation. And related to risk, what about substance abuse in adolescents?
Yeah, another critical area. Risk factors include things like a family history of substance abuse, poor academic performance, low self-esteem, or significant negative life events. The book mentions the CRAFT screening tool as a useful questionnaire for adolescents. But ultimately, the key nursing intervention here, beyond screening and referral, is prevention. We need to educate kids about risks and empower them with refusal skills, teaching them they have control over their own bodies and the right to just say no.
Prevention is always the ideal. Okay, that was a lot of ground we covered.
Yeah, it really was. But to try and synthesize this deep dive, we started with that really chilling statistic, right? That 4 out of 5 children with mental health issues are going unidentified. The solution, or at least part of it, lies in consistently applying the core knowledge we talked about today. That means understanding the power of consistent positive behavior management. It means ensuring advocacy through things like IEPs for kids with learning disabilities or ADHD.
Right.
Recognizing those critical early warning signs, like delayed language development for potential ID or the specific flags for ASD. Providing safe, truly life-saving care for eating disorders by understanding and preventing refeeding syndrome. And then those universal responsibilities. Your vigilance in screening for mood disorders and suicide risk, and the absolute non-negotiable duty of mandatory reporting if you suspect abuse or neglect. These are fundamental to pediatric nursing practice.
So considering that persistent gap in identification we discussed right at the beginning, that huge 80% of children who might be struggling but are flying under the radar, maybe the final thought for you, the listener, is this. What immediate, concrete step can you commit to taking in your own practice, starting tomorrow, to sharpen your observation skills, to listen more closely, and become a more effective advocate and early screener for the children and families you serve? That's the knowledge we really hope you carry forward from this deep dive. Thank you so much for joining us.